Welcome to The Met Show. I'm Dr. Rami Albahri, your host today. At The Met Show, we dive into the stories, research, and expertise of extraordinary people in dentistry, medicine, and entrepreneurship. Our mission is to help you become a more informed, critical thinker. Today, we welcome Danyah, a Canadian board-certified clinical pharmacist at Cleveland Clinic, Abu Dhabi. Thank you for coming on our show today.
Thanks for having me.
Of course. All right, so it's the first time we have a pharmacist, especially a clinical pharmacist. I'm actually very excited for today because I think we interact a lot as oral physician. I know it's a fancy word for a dentist.
It's
and
like
a pharmacist.
You're trying to be, but anyway.
Trying to be a physician, even though they keep calling us not real doctors.
Yeah.
But yeah, I'm very excited for this show to talk a little bit more about the pharmaceutical aspect of things. So let's start off with telling me a little bit about yourself and your education.
So I graduated high school, and from graduation in high school, I knew I loved chemistry. So when it came time to choose my pathway of, what I want to do in the future, I went for chemistry. And I started off with that. I loved chemistry labs because
so interesting.
That's when you kind of mix things together. And the thing I love the most.
Oh, I thought you were going to say that's when you found out that you were weird.
There's that too. Well, the weird part was I loved all the colors and mixing this and that's pink and setting things on fire and it would turn green. And I was like, wow, this is fun.
Such a nerd. Okay.
But then, so then after a couple of years in chemistry, my family is like, okay, what are you going to do with this? How are you going to sort of be a profitable person or someone of substance in society? How are you going to help people? So looking into other things, and my aunt is actually a pharmacist.
Oh, cool.
So
Okay.
she was the first sort of person in our family on my mom's side who's introduced me to the idea of pharmacy. And I looked it up as well while I was in university. And I actually grew to, the more I got to know it, the more I loved it because it's the perfect sort of combination of the whole nerdy chemistry stuff, but also people stuff, taking care of people, talking to people, helping them understand, sharing knowledge, helping them understand about their medications, their health conditions, and then also working with nurses, doctors, physiotherapists, dietitians, everywhere, just the whole medical field. It's a great sort of profession where you can combine all of these great things. So,
Right, that's actually very interesting. And I actually never thought about that because you are the center point, right?
Yes.
Because everybody refers to you, whether you're a dentist, you're a physician, you're a surgeon, you're a physiotherapist, whoever it is, they all merge into your field.
Yep, for sure.
That's very interesting.
So you need someone in the sort of, in a patient's healthcare, say, what's the word for it? Let me say someone when you have a patient's model of healthcare, you need someone who knows specifically about the medications because you want that person to help you with managing drug interactions, whether it's in the community or in the hospital. Right. It's either or. Managing the drug interactions, doing a medication review for all of the medications that they're taking. What is something we can take out of that? Deep prescribing is what we call it. Can we forego a medication? Do we need to increase this dose? Do we need to decrease this dose? So just having that person who's just looking at medications alone is a very useful part of the healthcare model. Especially with patients on multiple medications, like 25 plus medications. So complex, yeah.
So education in Canada, do you have to do a bachelor's degree and then you do pharmacy school?
Yeah, so minimum, I think, of 2 years for most universities. I'm not sure if it changed right now, but minimum of 2 years bachelor undergrad. So I did 3 years of chemistry. And then,
and where was that?
In University of Waterloo.
Okay.
And then after that, you go into Doctor of Pharmacy. So in Ontario, there's, which is the province in Canada where I did my degree, there were 2 pharmacy schools, Waterloo and Toronto. Waterloo is newer because it started about 2001, I would say.
Oh, wow. Okay.
So it's very new.
Yeah.
And the thing I like the most about Waterloo versus Toronto is we had the co-op model. So you would work for 4 months and then you would go back and study didactic learning for 4 months.
I love that.
And that way I found when I graduated after and when I precepted students from Waterloo versus Toronto, I found the Waterloo students to be more practical, but also they're aware of certain things in the workplace. Okay, I need to come on time. This is how I talk to someone. This is how I initiate a conversation with a healthcare professional. This is how they had certain responsibilities that maybe other students who had not gone through being a formal employee of a workplace. So being
more personable, basically.
Exactly. Or even understanding certain rules, what's done, what's not done in the workplace. Whereas someone else who's more green or new or doesn't know these things, you would need to kind of coach them and say, hey,
listen.
I
thought it was just like a Gen Z thing.
Yeah. It could be that. These days, they're telling us how to move. You know what I mean?
Okay, so you mentioned a hospital-based or a clinical pharmacist versus a community-based one.
Yep.
So is there at any point in your education where you kind of gear towards one or the other, or is it just an experience thing, or is it an extra degree, or what is that exactly?
So it really is how you get exposed to it in Canada, at least. I'm not sure about UAE and how they but I'm sure in their training, in every pharmacist training, you should get exposure to both, at least at some point in time. So I was exposed in my training and in my clinical rotations, and I did find I was sort of leaning more towards a hospital, mainly because I found it to be more complex and it helped me use the nerdy side, and I just liked reading cases. It was very clinical. I liked that. Reading the cases, understanding how I can modify the patient's medication profile and sort of add, delete, modify, increase dose, decrease dose. However, that being said, you can also be very clinical in the outpatient or community setting.
How so?
You can be...
Because I feel like, at least me as a dentist, whenever I'm prescribing something, they're just like... There's really no communication back. They're just like, okay, this one, okay, this one. So how can you improve communication as a community pharmacist?
Honestly, it really is up to the pharmacists themselves and how much initiative they put into being that person who sort of contacts the physician. Sometimes some doctors, physicians might find that person annoying at first, but once in a while, they'll actually catch something that you will find of substance or of use that will benefit the patient and be more practical for you as well as a doctor. And you might learn that, this antibiotic is twice a day versus this antibiotic 4 times a day. That's easier for the patient.
Better compliance.
Right. I mean, you learn these things, and I've had amazing examples of community pharmacists who really made some fantastic interventions that were helpful for the healthcare system in general, number one. Number two, the physician learned something, the prescriber learned something from sort of changing that. And at the end of the day, you want what's best for your patient. You want them to be compliant. Exactly. You want them to be compliant with what you're going to do. So that's in terms of the community pharmacist. In the hospital setting, you kind of get more into dealing with higher alert medications. Some medications require monitoring in the blood. So some antibiotics, they require us to help physicians, guide physicians on the pharmacology, pharmacokinetics of how a person interacts. And dialysis patients versus normal patients versus someone on major drug interactions. So just having that extra training to help guide the prescriber on how to adjust the dose. That's fun. That's the fun part.
Fun for you, but really stressful for us.
Yeah. Honestly, I've named myself a vancomycin wizard. But it's self-proclaimed. I don't know. Maybe other pharmacists will be like,
explain that. Explain that.
So vancomycin wizard is this is my own definition, is someone who knows how to dose vancomycin. It's a drug it's an antibiotic that needs monitoring in the blood because it's a very narrow therapeutic window. So that means it needs to be within a certain level in your blood, like say 1 to 10 or 15 to 20. If it's below that, then you're not giving them effective therapy. And if it's above that range, then you could put them at risk of side effects, toxicity. So you have to really help manage the dosing. Be
titrated really accurately.
Yeah.
Very interesting. Yeah, I think pharmacology was one of my toughest subjects
I hear that a lot,
in dental
actually.
school.
I wasn't great at it either.
So let me ask you this. Do you use an app?
Oh, many apps. Of course.
Okay.
Many apps.
Okay.
You mean
so it's not all in your head?
Of course not.
Okay.
Oh my gosh.
That's good to know because I always feel deficient.
No, 100%. 100%. Like, I don't think any of us, me personally, as in my practice as a pharmacist, I will, even if I know the answer, I will look it up and say, hey, just to make sure. I mean, sometimes, dose of whatever, you know it off the top of your head. But more often than not, just because I want to give the right answer for the right prescriber, especially if it's a high alert medication, I will say, let me look it up.
Right.
Let me be sure. And I actually cross-check with 2 or 3 different sources if I really want to be. If it's something I've never encountered before, I cross-check with 3 or 4 different sources at least before I give the prescriber my recommendation. So the apps we use, the major one is called UpToDate. I'm sure you've heard of it.
Okay, yeah, of course.
It's like the medical Google, but legit medical Google. It's not free, so it's only for healthcare professionals. There's LexiComp drugs.
Yeah,
so
that's also very popular.
Yeah, it's in the LexiComp drugs. So that's what we use every single day. I use that. It's on my phone. I eat, drink, sleep, UpToDate. There's other ones that we use specifically for different things. So if it's an IV medication, intravenous medication, we look at a different source. If it's, there's also Micromedics. There's also the one I like to use is called Sanford's Antimicrobial Guide. Have you heard of that one?
No, I actually didn't.
That one's really good at telling you what antibiotic covers what bugs.
More specific.
More specific.
I guess that's after culturing.
Exactly, culturing, or even for empiric therapy. So if you suspect somebody has an infection and you don't know what to treat or what antibiotic to start with, it will tell you start with this to cover most of generally what this. Say it's in the stomach. Stomach bugs are usually this, that. So start with this and go from there, essentially.
Question. I'm sure, especially now, we live in Abu Dhabi and we're very insurance-based. Is there a difference between a brand name antibiotic or brand name anything and a generic form? Because a lot of, I know at least from my patients, they're always complaining the pharmacist gave them the generic rather than, let's say, for example, amoxicillin. They give them the generic amoxicillin rather than Augmentin.
Yeah.
Is there an actual pharmacologically, is there a difference or is it just psychologically?
I'm laughing because there's a lot of social, the social aspect is that living in a country that's, alhamdulillah, given us so much comfort and care. You actually have that luxury aspect of things. So you're like, I want the brand name or nothing. Give me brand name. So in general, the generic drugs, their studies before they are out on the market, they have to prove that they are the same level in your blood as the brand name. So from a sort of quality perspective, no drug will be out on the market, no generic drug will be out on the market unless it has proven that it can achieve the same, that it can achieve the same levels of the drug in your body. So that's number one. Number two, I will say the caveat is that sometimes some medications have different non-medicinal ingredients. So the medicinal ingredient is the exact same. But what generic companies do is change the non-medicinal ingredients. Just
because maybe there's a patent on it or something like that, they have to change it up a little bit.
Exactly. And that's where somebody might have a difference in how they react to it. So that's where it might agree with you, but it won't agree with me.
Gotcha.
And I've seen patients, sometimes they say, oh, I love this brand, but I don't like this brand. And it's a generic brand, not a brand name, like not the brand name. So it really, what I will say, depends on how your body reacts to it.
Okay, so there is a difference, but it's minute.
Exactly,
Okay,
exactly.
Gotcha. All right, let's dive into a little bit on over-the-counter supplements. Let's start with supplements.
Okay, sure.
What are your thoughts about multivitamins? A lot of people are pro multivitamins, and a lot of people just say that's just expensive urine. What's your thoughts on that?
A very nice way of putting it. Very nice. So essentially, if you're a healthy person with no medical conditions, the National Institute of Health, which is the sort of America's guide on how to take medications, how to do things, how to live life, how prescribers should prescribe medications, essentially. They say if you are a healthy person with no medical conditions and you're having a well-balanced diet,
and that's key.
That's very key.
Yeah.
A well-balanced diet, then you probably do not need a multivitamin. What they said is it's not going to harm. It may not help, but it's up to you at the end of the day. If you want to be proactive and take it, it's not going to harm you. Okay. But it may not help you either. But maybe you take it, you're part of the percentile population where it helps you a lot. Or maybe I'm the percent of the population where it doesn't make a difference at all. So it depends on...
But what do you think about placebo? We all know that that's actually been clinically proven that placebo works.
Yep.
And maybe it's just a placebo effect and ignorance is bliss.
Yeah, exactly. It could be that as well. So we'll take it.
Very interesting. What about vitamin D? I think lately there's been a big craze on vitamin D.
Yep.
We found out that majority of the population in the world, and ironically UAE, which is one of the sunniest places in the world, are very deficient in vitamin D. And we all know the side effects of being deficient in vitamin D goes from depression to bony issues and all that stuff. 100%. So what are your thoughts on that, on supplementing vitamin D, whether you're deficient or not, and should people be continuously checking if they're deficient in that?
100%. I think at least, if not once a year, once every 2-3 years, if you're a normal healthy person, maybe once every 3 years or 2 years, it'd be worthwhile checking your vitamin D levels. And if you are deficient, then you definitely would need supplementation, whether it's like a daily 1,000 unit tablet or something more intense, like a weekly or bi-weekly injection, whatever it is needed based on what the prescriber thinks and your lab work. It is a lifestyle thing, maybe because we, as in the UAE, when it's hot, we don't go out as much. Right. So we're not getting that sun exposure. Right. So there's that.
And all our cars are tinted.
Exactly.
You're indoor, you're going from parking structure to parking structure.
Exactly. Yeah. So you're not getting that sun exposure. And there have been a lot of studies on if you've had a fracture, that it's something useful to supplement with, especially in the elderly population. So even whether or not, regardless if you're low or not in that population. So it really depends on your case. But in general, it has been in the past few years, as we've stayed home more, we haven't been exposed as much to vitamin D. So it's worthwhile getting checked.
I agree. We as dentists, or at least as implant surgeons, we love vitamin D. There's been a lot of studies. Initial studies started off as they were looking at the implant survival rate of people who are deficient in vitamin D and people who are not deficient in vitamin D. And they found a statistically significant difference between people who are not deficient. They took it a step further and they were like, those two individuals, or let's say in this randomized controlled trial, they're both not deficient. But let's add a supplementation for vitamin D and let's see the success rate for the implants. And they found that it is statistically significant. So whether, at least for us as an implant surgeon, whether you're deficient or not, I always advise the patients, please start taking vitamin D before we go ahead with these implant surgeries or bone grafts or whatever it is, because it actually enhances the survival rate. So we are big fans of that.
Of vitamin D.
And me personally, I do take vitamin D like almost every day.
That's good. No, it's really good. And I will say it's excellent that you do that, because you have data and studies that back up the fact that my implant will work better if you take this, but at the prescribed dose. And all that stuff.
Exactly. What about vitamin C? I think the world is obsessed with vitamin C. I think the recommended dose, correct me if I'm wrong, but the recommended dose is like 250 milligrams. But you look at the pharmacy and they see all these tablets that no less than 1,000 milligrams in every single one. And people basically overdose on those antioxidants. What are your thoughts about that? And is it necessary?
So most, based on what I've known and what I've seen in research, most of the time for a common cold, vitamin C has not been shown as a direct link to help with the common cold. But maybe a naturopath might say differently. They might say, actually, the antioxidant does help with this, that. A shout out to my really good friend, Maysam. She's a naturopathic doctor. So
I guess you guys bump heads a lot.
Yeah, it was fun time, but it's a good bump head though.
Okay.
I miss her so much. So, every sort of professional will tell you differently. Now, where I had a personal experience with vitamin C is just making, with my mom, she had some kidney stones. And when I looked up a little bit what could have precipitated kidney stones, literally precipitated kidney stones, is intake of vitamin C.
Interesting.
Beyond 1,000 or 2,000. So two different studies looked at 1,000 versus 2,000. And I think it was the supplemental tablet form, not just your vitamin C in the food. That could have put you at risk of producing oxalate, which is the stone that sort of precipitates in your kidney. So for someone who is a kidney stone former, I would say maybe don't supplement with vitamin C, especially over 1,000 or 2,000 milligrams. For other people, we know it's a water-soluble vitamin.
Right.
So anything you take in
expensive urine.
Exactly. You're just peeing extra stuff out. So the rest of it is not going to be useful.
It was very interesting, actually. Vitamin C is an antioxidant.
Yeah.
And this has not been scientifically proven through randomized controlled trials, but there has been a lot of case reports that showed that it interacts a lot with local anesthetic. So for us as dentists, when a lot of times we have like a stubborn tooth where we're just anesthetizing and everything is numb, but that tooth is not anesthetized, or you're not being able to get that patient numb. And there was some links, let's say at this state, and at this stage, it's a very weak link, but with anesthesia and vitamin C. There has been, for example, another random link of people who drink a lot of camel milk.
Oh,
yeah, especially here in the UAE, and I think in the Gulf countries, they drink a lot of camel milk, and lack of anesthesia. So a lot of people who, like you need a much higher dose of anesthetic for them to get anesthetized. So we hate it because we can never get the patient numb.
See, this is the importance of always double checking with your provider. Even something as simple as vitamin C, I wouldn't have thought that it interacts with my anesthetic with going to the dentist. You know what I mean? Like, that's why I think it's very important as anybody who takes anything, just to let your provider know that, hey, listen, I'm taking this. Is that okay? Do you care? And most of the time they'll say, oh, I don't care. But you just be safe, be on the caution side.
And I think it's also our responsibility to also probe those questions. Because I know a lot of, at least for dentists, they don't see themselves as oral physicians. They're just like, I'm just a dentist, I'm going to drill and fill,
Exactly.
So, but it's very important to ask these questions, at least in the beginning of an appointment. And it also makes you seem more legit to the patient. Be like, okay, they actually care about my overall well-being.
100%.
Because everything's related to the oral cavity, right? Like lately, we had a podcast, episode 5, where we talked about how there's a bacteria in the mouth that produces some sort of protein, and that harmful protein were found in the brains of Alzheimer's patients.
Wow.
It's not found anywhere else except there. So there has been a link between periodontitis and Alzheimer's, which is very, very interesting. So it's the beginning of the digestive tract, and it's extremely important.
Sorry to interrupt, but there's a huge link they're saying between the digestive tract, and it's almost like another neurological system.
Yes.
And it's connected to your brain.
Yes. And there's actually the second place that has the most neurons is the GI tract. First, obviously, is the brain, and then comes the GI tract. And that's why I think also when we talked about in episode 5 with Khalil Ramadi, he talked about how we can stimulate the body through electronic pills, because we know that instead of implanting an implant or an electronics into the brain, we'll just have the patient swallow it, and we have all these
It'll
neurons in the
follow,
GI,
you have all
and
that
then does
signal.
all the electrical stimulation
Wow.
through the GI tract. It was actually very interesting. So yeah, it's very, very true.
Medicine is crazy interesting.
Yeah, very, very interesting. That was an interesting podcast. Okay, moving on to something not over the counter, antibiotics.
Okay.
I think antibiotics is massive.
Yep.
I think that changed humanity.
Yep.
I think penicillin was discovered in the 40s,
Yeah.
I think. And that completely changed the course of humanity.
Yep.
Unfortunately, I think nowadays we are abusing it. And it comes from pressure, or it comes from lack of knowledge from doctors and patients. Exactly. Patients are demanding it and think that the doctor is no good if he doesn't prescribe it. What are your thoughts on that, and what are the consequences of that?
First of all, I will congratulate you as an excellent oral physician for practicing antimicrobial stewardship. Okay?
Thank you.
I'll
It's
give
an
you a
honor.
pin.
I love it.
So, what is antimicrobial stewardship? Is basically practicing appropriate antimicrobial prescribing. It's known all over the world. I think ever since 2015, the World Health Organization has been saying, listen, we're in trouble because we're running out of antibiotics that are going to be useful for us. We're running into so many resistant bugs that we don't have any more antibiotics to treat.
And we're seeing that with like MRSA and stuff,
Exactly,
right?
100%. And in the hospital is where I definitely see it more. Because we see all the cultures, you see essentially whenever you come in, say you come into the hospital, you have an infected wound on your foot. We take a swab of that. La samahallah, it goes to your blood. We take a sample of that. We put it in the lab. We take a look and see what antibiotics can I use against this bug to kill it completely once and for all. Bit by bit, we're starting to see more and more resistance. So that means I cannot use this antibiotic. We used to have sort of a panel with 15 antibiotics that we could use, whereas now we're seeing more and more resistance. So that number is lower now, it's 3 or 5. And that's scary because let's say I treat you now with one of those 3, but then the bug starts becoming or learning how to fight against it. And now it will become 2. And then...
Right.
And then you'll come in next time with another infection. You come with another infection next time, and then I'll have 2 choices, and I'll use one of them. And then next time it'll be resistant.
Right.
So then we won't have any more choices. And that's when it's really the saddest, sort of most difficult position to put prescribers and providers in.
Right.
Because you want to help the patient get better, but you literally ran out of sources. So the idea of antimicrobial resistance awareness is very important for patients specifically, because even my mom the other day, she said, oh, I had a little cold. Should I start taking an antiviral? And I said, it's just a little cold.
What's worse is some people say antibiotics when it's a virus.
Exactly.
And that makes it even worse.
Exactly. You're basically, there's a virus, there's bacteria, there's fungus.
You're right.
So all these 3 are different sort of bugs, parasites that you need to treat. And the other thing that's important is that, say you are colonized, you're a healthy person colonized with something that's that's resistant. Say one type is MRSA, you mentioned. So that's methicillin-resistant Staph aureus. It's just a type of bug
Bacteria.
that's resistant to methicillin, which is penicillin. It's sort of that type of class of antibiotics. So say I am colonized with it, but I am in contact with someone who's immunocompromised. And
especially in a hospital setting.
In a hospital setting, exactly. And I pass that, unfortunately, onto that person, and they become infected with it, and they need to get treated with it because their immunity is not as good as mine. So they will sort of get that bug, and we'll have to treat them for it. There's a whole department in every single hospital called infection control. And their job is to make sure that us as providers do not pass on these bugs from one room to the other. And that's why we want to minimize your stay in the hospital, because hospital-acquired infections are a huge deal.
Huge deal. It's a big cause of death.
Exactly.
Let's put it this way.
Cause of death, it's costly. The length of stay is doubled or tripled, whatever, because you you get something from the hospital and we have to treat it, right? So, and it's usually something more intense than your usual stuff bugs that are out in the community. So,
antibiotics is definitely becoming a difficult thing to manage because we get it a lot. Like, and the issue, in my opinion, it narrows down to two issues. One being patients' pharmacological IQ and compliance. Because a lot of times patients are not taking the medications as prescribed, or they think that it's necessary when it's not necessary.
100%.
Because it happens a lot with us, especially when we're extracting wisdom teeth. We remove the wisdom tooth and they're like, hey, I want antibiotic. Like, you do not need antibiotics. And of course, with any tooth extraction, what ends up happening is, or what we want is that blood clot to stay inside the bone because that promotes the healing. So obviously the patient does not follow instructions, then he starts getting a lot of pain, and then he comes back being like, hey, I told you I should have taken antibiotics. This pain is because I did not take antibiotics. And then some doctors know that it's not necessary, but just pressure from the patient, they just prescribe it to just take that headache away. Which is very wrong, but sometimes it happens.
It puts you at
a very uncomfortable position. A very uncomfortable 100%. Position. So what are your thoughts on trying to improve patient compliance? Do you think technology could help us with patient compliance?
Honestly, I think awareness and just having these good sort of discussions with the patients, telling them, using technology in terms of using radiology to show that, hey, listen, I took a photo, it doesn't look infected. I've been trained. I have my tools that tell me if it's infected or not. I, as a physician, believe it is not infected, so you do not need antibiotics. And why will I put you at risk of A, B, C, D? Because taking antibiotics has its risk as well, right? You're not
taking anything has its risk,
100%, 100%. And I'm not just wiping out the bad bacteria, I'm wiping out the good bacteria. And sometimes when you wipe out the good bacteria, it lets other bad bacteria come and colonize.
Exactly. And that's the big thing that happened in dentistry lately. There's been a huge shift on mouthwashes. We actually stopped prescribing mouthwashes. Because before, always the protocol is you brush your teeth, you floss, you use a mouthwash. But now we found out that obviously in the mouth there's good bacteria and bad bacteria. And then we stopped using mouthwashes because they kill all the bacteria. And sometimes we need that good bacteria to keep that balance, the homeostasis of the oral cavity. So you're absolutely right.
I think, so some of the sort of causes of antimicrobial resistance is, like you said, patient compliance. So stopping the antibiotics before the full course. Say you've given 7 days antibiotics, but they take it 3 days, they feel better. They're like, oh, okay, that's fine. I don't need any more. I'm getting diarrhea anyway, so let me just stop. But no, you have to continue for the full course, because when you reach that half course, you're teaching the bacteria on how to fight this antibiotic. So that's one. Two, like you said, overprescribing. Like the CDC, I think they said 30% of outpatient antibiotic prescriptions are actually not needed. They're just prescribed for whatever reason, pressure, like you said, or they want to, maybe the provider wants to sleep better at night and say, okay, take this. And sometimes they prescribe it and say, if you start to worsen, take it. But it really depends on prescriber practices and raising awareness on how big of an issue this is and how we need to mitigate it by raising awareness and education.
I agree. And I think another thing we need to increase awareness in is blood thinners. I think a lot of patients are on blood thinners and they have no idea they're on blood thinners. And they come to us and I'm like, okay, can you tell me about medication? Oh, I'm not taking anything. I'm only like, oh, okay, what are you taking? Oh, I'm taking warfarin, and I'm taking this, and I'm taking that, and Coumadin. I'm like, this is important for me to know.
I think that's the biggest thing that I've seen. Like people, not people, but in general, patients are, I guess, not, they don't view these things because it's so used to them that, I'm on aspirin, I'm on warfarin, I'm on Eliquis, I'm on this, on that. They don't see it as something that could be a really risky thing, risk versus benefit. It can, if it goes wrong, it can go wrong. So true, it's rare to go wrong, but at the same time, it is something that you're introducing to your body that could cause a lot of harm and side effects, right? And actually, a funny story about blood thinners. We had one lady who was on, going back to supplements, I think I told you this story. She was taking a supplement of vitamin K plus, I think it was vitamin D plus vitamin K. And she was someone who was at risk of clots to begin with. She had some issues with bleeding and clotting, and she was admitted to the hospital with a new clot. And we thought it was unprovoked, or we don't know what the cause was. But when we did the whole sort of medication history, medical supplement history, we found out that she's taking this regularly in addition to another medication that might have exacerbated this clot. And it just shows to tell you that supplements, something as simple as a supplement, can have severe consequences.
And tell your physician.
Exactly. That's the if there's one take-home message, is tell people what you're on, and have a list with you all the time of all the medications and all the supplements that you're taking.
And then honestly, that's the beauty. And I love the initiative that DOH did in the UAE is Malafi.
Oh,
man, that has completely changed my practice.
So much.
Not only knowing when bad dentistry is being done, and I know exactly who's the dentist who did that, but also to understand the medical history and the lab reports. A lot of times I ask patients to get me the, let's say, HbA1c for the diabetes or whatever it is. And actually I would know the result before they even know it. And they're like, oh, wait, how did you know that? I'm like, oh, I went into Malafi and I found out. And now we can go ahead with this implant. And it's really had... I think took the responsibility away from the patient. So I think this is where like it's a double-edged sword. Because the patient is now like, okay, I don't need to remember my medication. I don't need. The doctor has the information and it's his responsibility to check it.
كله في السيستم.
كله في السيستم, exactly. So it is a double-edged sword. So when we as like, let's say westernized healthcare providers, we're trying to change the community to become more a good way you said it off camera was to be participants in their own health. We're promoting that, yet technology is making it easier for them to not participate in their health. And then it's up to us to make sure that everything is on point.
Honestly, I like that point, but at the same time, why don't we just put both together? Engage them, be a participant in your health, but also use the technology to help us out as a sort of backup. So when I take a medication history from a patient who's just admitted to the hospital, I go by what they say, but I also say, do you have a list of medications? I use Malafi. I use ambulatory profile, whatever I can see on the system, because I trust you as a patient, but I don't trust you.
Patients lie. Patients lie.
Or like, what if they forgot that they're taking it half a tablet? Somebody told them to change the dose, but on the system, everything's on the system.
Everything's on the system.
But the system's not always right. What if
because maybe the doctor didn't write it.
You know? Exactly.
So that could be, there's always human error there in the system.
Anytime I go into the hospital and I say, oh, I'm here to do a medication history, and they're like, ليش كله في السيستم? And I was like, okay, I know, but I just want to make sure because maybe يمكن قال لك تاخذ this, or maybe he told you do that, or maybe قال لك اتوخر, or you know what I mean? So
absolutely.
It's good to be thorough and ask all the questions. Always question. For both providers and patients, always question everything. Never take anything as face value. You always have to have that hint of doubt. Okay, maybe somebody was told this, but you always have to ask for sure.
Absolutely. Okay, moving on to another hot topic. Ozempic.
Oh, yeah.
I had an amazing conversation with my brother, Dr. Shadi. We had a huge talk about that, especially him being a bariatric surgeon. And how Ozempic kind of changed his field. So I'm sure as a pharmacist, you're seeing a lot of prescriptions to Ozempic.
100%.
And I feel like a lot of times it is over-prescribed, as most things are in pharmacy. What are your thoughts on that?
That's where we make all the money, Honestly, pharmacy as a profession is definitely money-making because of not just sort of regular medications. It's kind of weird, going on a tangent, sorry, but it's kind of interesting to see how these big pharma companies are developing these really expensive medications, but they're making it as a part of, or the way they're marketing it is that this is essential for their patients' well-being. And sometimes it might be true, but you really have to look at your patient and sort of decide, is this indicated? So the thing I loved the most about my training in school, they taught us every single medicine you come across in a patient's profile, use the IESC method. So I stands for indication. Is it indicated? E stands for effective. Will it be effective at this dose? S stands for safety. So will it be safe for them at this dose? Does it need to be dose reduced based on their kidney function? Or does it need to be dose adjusted based on other factors, their weight, their height, or whatever? And C, will they be compliant on it? So are they able to take it times per day, or will it cause side effects that will cause them to stop it? So having that framework when you're assessing if Ozempic is right for your patient is really essential, I think.
Yeah, but that's literally where the issue lies, right? It's not indicated, and they're doing it for aesthetic reasons. I don't have anything against Ozempic. I think it's an amazing drug. It's helped so many people live healthier lifestyles, not become diabetic, lower their blood pressure, all that stuff. But sometimes a normal-looking person, an individual, is just on Ozempic, and the latest research showed that there is a link to blindness. Taking Ozempic, which is pretty
that's a big one.
It's a big one to sacrifice just to be skinnier. You know, and generally speaking, we hate it too, because especially when you first take it, it creates a lot of nausea. So the second the patient comes in and they've taken that medication or taking that jab, I'm like, come back in a week, because the second I do anything in the mouth, you're gonna start gagging. And the other side of it is some physicians are against prescribing those, and then they take them off markets, because there's a lot of actually fake Ozempics and fake jabs that are mixed with you don't know what, that are coming from I don't know where, and people are taking them. And that's the scariest part, is that we're trying to do our part by limiting, and then other people are taking advantage of that. Exactly. And they're just like, and taking this no brand name, let's call it, going back to that, it's like, and that could be even more harmful. 100%. So yeah, I think just our responsibility is just to create awareness and 100%. Make sure that patients are, again, like you said, it is participating in their own health, because at the end of the day, it's our health, it's our responsibility before the physicians. The physician is trying to help, and we're trying to help as many people as we can. But ultimately, it's your responsibility. I'll
tell you what it is. I think it's us, maybe as younger people, if you're younger, healthy, you kind of want to say, hey, let me experiment here. Actually, I know a couple of people who've just say, hey, let me see if it does anything for me. And that feeling of nausea or fullness or satisfaction is what makes them eat less. So they feel that's life. Works for them.
That's life. Like, imagine eating a chocolate bar and not enjoying it. Live for that.
Exactly. I'm part of the live to eat.
Same. It's crazy.
It is interesting. I mean, everybody's free to their own will, but I will say that every single medication, if that's one important take-home message, any single medication you're taking is you're introducing something new to your body. Ozempic, blood pressure medication, diabetic medication, anything, no matter what it is, you have to know what are the potential side effects and what you can do to mitigate them. Is it a serious side effect, or is it something I can manage at home? Is it something I need to go to the hospital for? Read up on any medication before you start it, or ask a pharmacist, ask your physician. Your physician might not have time to go into details, but ask your pharmacist. Pharmacists are chilling in the pharmacy. Okay, maybe they'll say, maybe they'll hate me for this, but just ask, look up, and don't look it up on Google. Go to reputable resources.
Not Dr. Google.
Not Dr. Google. Reputable resources could be like Mayo Clinic, Cleveland Clinic.org, just any, up to date, but ask your pharmacist or physician to give you a patient handout. The manufacturing sort of label itself in the box will tell you more information. They usually list all the possible side effects. But because they want to cover the butt. But you have to see what is relevant to you. What if you're on something that interacts and it could cause the side effect or whatever? You have to know the risks and benefits of starting a new medication. And hopefully every I just want you to be aware to ask these questions as a patient.
Yeah, absolutely. I think You nailed it.
Yeah.
So we'll leave it at that.
Yeah.
I think that's a good way to end this. And I would like to thank you for spending Valentine's Day with us.
Oh my God. Happy Valentine's Day to you and Yasmin.
Thank you. And if there's anybody that wanted to collaborate with you, can you share your email? Can we share your email or anything like that? And obviously, this is all evidence-based. We're going to put in all the resources that we use to have this talk. Yep. And again, I would like to thank you for this. This has been a lot of fun. I really enjoyed this.
Before we end, actually, I'm going to ask you, what's your favorite drug? Do you have a favorite drug?
Every dentist's favorite drug is Augmentin. That's literally, you cannot go wrong with that.
Oh my God. Antimicrobial resistance.
You cannot go wrong with that. That's like probably 99% of my medications.
Augmentin. Oh my gosh, yeah.
Yeah, 1 gram. 1 gram. For compliance, right? I don't give the 500 milligrams 3 times a day, just twice a day.
Go for it.
That's a good one.
What can I do? So funny.
I am part of the problem, I guess.
Yeah, you are.
Oh,
Thank you so much.
Thank you. I appreciate it.